How long has the LVAD been around? The LVADs have been around for quite a while. Actually, it started as a short-term bridge device back in the 80s and 90s, but they really took off in the 2000s as long as a term sport. So now they're often used as a bridge to transplant and even destination therapy. Excuse me. The medicine I take gets me to having a dry mouth. So, yeah, I hope you guys will forgive me for that. Which hospitals have implanted LVADs? Duke University has implanted over 1,500 LVADs since 2003. UNC has implanted over 500 since the early 2000s. Sanger Clinic in Charlotte, I don't know if you've ever transported to it, but the Sanger Clinic is actually behind the hospital. It's a freestanding clinic, and they've done over 500 since the early 2000s. Novant Health is a VAD hospital, meaning it can manage care for patients with LVAD. Cape Fear Valley Hospital is also a VAD hospital. Doesn't implant the device, but is capable of treating someone with LVAD problems. This is a HeartMate 3. This is what they're currently installing now. Um, Medtronic had came out with a LVAD that did nothing but give problems the whole time, so that they discontinued the use of it. This is other LVADs. You got your HeartMate 2, um, Aeroline Heart, and you can see in the bottom right hand corner how they are inserted. This is a to-go bag. You'll notice there's two batteries, a spare heart controller. Um, this is what these patients carry with them whenever they go out or whenever they have to go to the hospital. If they got to go to the hospital, make sure that you grab this to-go bag. What procedures does a patient with an LVAD have to go through to get the LVAD? It's a pretty rigorous process. First, there's a full evaluation, cardiac test, echocardiograms. They catheterize most of your coronary arteries, and sometimes the right heart cath, just to make sure that that's clear and open. When you get a full medical workup, things like kidney, liver, and lung functions, and they screen for things like cancer. Um, what's the importance of putting an LVAD in if the patient has terminal cancer? Um, Once that's all stable, they will make a psych exam, so the person who's getting the LVAD will be psychologically ready for the LVAD. And there's also a social evaluation that just makes sure that the patient is set for long-term recovery. Um, and finally, once everything checks out, they get listed on the transplant or destination therapy. It's definitely a marathon, not a sprint. Social service team may come out to the house to make sure the patient is able to live in a relatively clean environment, and precautions have been taken to receive the patient. Who should get the device? The criteria for left ventricular device or LVAD usually apply to patients who have heart failure, who have responded to went to the hospital multiple times with heart failure. Um, Key thing is low ejection fraction, like 25 to 30%. Not like I say, frequent hospital visits. It can be used for a bridge to transplant or long-term destination therapy to help a patient recover. It's not appropriate if there's signs of right heart failure or end organ damage, or if the patient can't manage the device care. Is a VAD implantation an open heart procedure? Yeah, it sure is. When they implant an LVAD, they open the chest to assess the heart. It's a big deal. It's kind of like heart surgery event, except they don't take the heart out. They just insert the device in the left ventricle and they insert a tube into the aorta. So they place the pump and they want to make sure everything is working optimally, and they get started on anticoagulation medication for the pump and the body keep from making clots. A lot of these machines will purge themselves every 2 to 3 seconds just to make sure they don't make a clot. How long is a hospital stay after implantation? It's not a quick in and out deal, that's for sure. People usually stay anywhere from a couple weeks to a month. The exact timeline depends on how smoothly they recover. If they do well, they can go home in a couple weeks. But if they're having a hard time dealing with it, they'll want to make sure the patient is stable, confident, the device is ready to go and managed at home before they let them out the door. Also, a caregiver needs to be assigned to that patient who is with that patient 99% of the time. Uh, these patients can't be left alone anymore because there's so many things that could happen. Is there a requirement for backup power in case of an outage? I would say yes. For someone with nail bed, you don't want to gamble with the power outage. Backup power source like extra batteries, a generator, or backup battery system is usually a must. That way, if power goes out, you still got juice to keep the pump running. Uh, it's a key part of the plan to keep things safe and steady at home. This is a picture of a right and left ventricular device. You'll notice that the right ventricular device is adjacent to the LVAD, and sometimes they call these bivads. Uh, so, well, if it's a bivad, I think it just has one drive line coming out and then splits off into left and right ventricle. This is another picture of an RVAD, LVAD, or bivad. You can see the left ventricular device, and then you see the right ventricular device, and then you get the driveline cables coming loose. So that's your what's called your bivad. This is kind of what it looks like when they get ready to go out. They have a holster type uh, battery case. They have the lines that run from the batteries to the controller, and they have the drive line from the controller to the pump itself. Is sepsis a concern after implantation? It sure is. Definitely keep a close eye on that. Any major surgery, especially one involving the heart, brings risk of infection. Sepsis is a concern, so they'll give antibiotics and monitor signs of infection. Once you get home and once the patient gets home, that's another still big topic. Um, Sometimes I have nurses come out and care for the bad patient, and they get followed up right at home. Nurses would check the device, monitor vitals, and make sure everything is going smoothly. It's all about keeping them stable and supported after the big transition home. Now, these exits, I would say, of the battery and the drive line, uh, they have to be kept in a sterile environment because they can really get infection easily, and your patient will go back to the hospital. What are two types of therapies for LVADs? So the two big categories is bridge to transplant, where the LVAD is just a temporary support while they wait for a donor heart. That's your more healthier, well, that's your sicker patients, where they still have a lot of viability to them, and this LVAD is just a temporary thing, so that when the new heart comes, they can readily get that and be on their way. The other is destination therapy. It's where the LVAD is a long-term solution for patients who aren't candidates for transplant, sorry, but both really transform care. There's a chosen base of patient situation in the prognosis. Renal failure, end organ failure uh, would more than likely be a transition or a dependent care. So LVADs typically have few moving parts. You get the pump itself, which sits inside the chest. It takes over the pumping action of the ventricle, and what they do is they drill a little like a little apple core and the bottom of the left ventricle and insert this thing. Um, they insert it as like one size. Well, they make the hole one size smaller than the actual device, so they can get the muscle around it, so they can attach it to the mesh that comes um, with the LVAD, so it's sutured in place. And like I say, if you put something, man, make something, it can be broken. So um, it's got as few moving parts as you can imagine. Uh, the controller and battery pack sit outside, kind of like a little backpack or a waste unit, and the course of the whole system is connected to sensors and can adjust pump flow. Now, this little pump will has a pump speed between 480 and 960 RPMs. Now, if you think about the way a pump works, if it's full, it's going to pump slower. But the less volume it has, the faster the impellers turn. So at 4,800 RPMs, it's capable of moving a large amount of blood each minute, depending on the patient's size. Speed will be adjusted for the proper calculation of cardiac output. What the heart depends on. LVAD patients tend to be pretty much preload dependent since the pump relies on a certain amount of blood returning to the heart to function effectively. And they're afterload sensitive too, meaning any changes in the systemic vascular resistance can affect the pump's ability to push blood out. So you have to be super mindful when assessing these patients. When you assess these patients, more than likely they're not going to have a pulse, and you'll feel a, a, I'd say a hum or a thrill. But when you go to take a blood pressure and you take it manually, you need to use a Doppler so you can get a sort of accurate heart rate. So um, all this revolves back onto your really primary assessments. You look for your mental status, cap refill, skin color changes, respiratory effort. Uh, Look for all those, and you continuously reassess. Um, you'd like to have your mean arterial pressure around 60 to 65. Um, this one I thought was kind of odd because I had somebody ask me this uh, as I was doing a paper. Can LVAD patients get nitroglycerin for MI? So in general, you do need to be cautious. Nitroglycerin reduces preload and can drop blood pressure, and the LVAD patients are prone to uh, or preload dependent. So it's typically no big issue. I mean, I'm sorry, it's a no-no unless you've had some really clear parameters and are working closely with the cardiologist team. It's always a good idea to double check the specifics of the case before you give it. Can patients get dehydrated? Oh yeah, they have to intake uh, at least 1 to 2 liters a day of water so they can get that 30 milliliters of urine out. Get the urine out each day. They they will dehydrate quickly because um, they get the heart pumping at certain speeds. They may get a case of diarrhea. They may have an infection that causes them to have a high temperature and sweat. Uh, so keep an eye on the hydration status. If they're on diuretics and they're not drinking enough, then yeah, you need to establish a line and get their the pressures back to normal. What other complication once home from the hospital? So aside from the risk of infections, you have to watch out for clotting issues. Like these pumps can backwash every 2 to 3 seconds and try and keep from making clots. These pumps are also medicated. Uh, they're anticoagulated, so the slim chance of making a clot. They also need to manage your fluid balance. As LVADs are sensitive to preload, are we getting a picture here? Uh, they're they're dependent on preload and sensitive to afterload. Plus, they've got to stay on top of their driveline. Driveline coming out of their abdomen needs to stay clean and secure and sterile. Oh, and adjusting to lifestyle changes, limiting certain activities can be challenging, but with good support, they can pretty well manage their own. Urine flow is a major concern. Um, Check color clarity and also check for odor. Let's see, I lost my place. What is in a go bag for an LVAD patient? So a LVAD go bag is kind of like a lifeline. You're packing backup batteries. There's always more than what you think. Plus, there's a separate controller in the main. When if the main one glitches, you want to charge charging cords and extra drive line dressing kit to keep that exit site sterile, and any documentation or medical contacts. Oh, and don't forget snacks and water because emergencies don't care if you're hungry. What you do in a crisis? Get your own duty medical control or the receiving facility's cardiology team involved as soon as possible. If it's a major crisis like signs of pump failure, when the LVAD cord, you need to go contact the LVAD coordinator or specialized cardiologist should be brought in. And of course, if there's any doubt, just get them to a facility with a VAD program, um, like right now, because they really need um, care. And these people will really look sick. So, um, what is the life expectancy of VAD patients? For some patients, the LVAD survival rate is about 85%. They're alive for at least a year and around 70 to 75% at 2 years. Longer term shows about 51% after 2 years, at up to 7 years, and some destination therapy patients reach about 75% after 5 years. It's important to remember that LVADs are lifelong. They're not an automatic cure, and the outcome really depends on the patient's conditions and complications. On YouTube, there's a young guy. He's in his 30s, and due to drugs and alcohol when he was younger, he wrecked his heart. So they put him on a LVAD. Well, this guy took it to extreme. He worked out, ate right, um, did everything that he was supposed to, and after about 3 years, he finally come off of his LVAD completely, and now has a normally functioning heart. So the LVAD's not um, to be a end all be all for a a destination therapy. Um, it or a beginning to transition. It can actually help the heart regenerate and rebuild and get the myocardial tissue to regrow and you uh, get healthy again. What should EMS consider? So when it comes to EMS patients and LVAD, it can get a little complex. You really want to keep an eye on perfusion. Watch for signs and symptoms of pump failure and shock. Be cautious with things like defibrillation or pacing. Like I say, statistics say that 1% of the EMS population would deal with an LVAD patient, but with all the LVADs that Duke is implanting and UNC Chapel Hill is implanting and other areas that are implanting, um, that population is going to grow. And the older we get, the more it's going to grow. So you can expect that percentage to increase. Uh, these patients, you have to watch for thrombus or a stroke or pulmonary embolism should be of high concern uh, when you go to them and they're showing signs of altered mental status or sharp chest pains. Um, for that altered mentation and chest pains, that's an emergency transport to a facility. Um, Most VAD devices purge themselves. So you may have time to get to an LVAD facility if patient is stable enough to get that far, or your medical control may order you to transport to a medical facility that's capable of handling that. CPR. It is recommended that CPR is needed. It should be manual CPR. Mechanical devices show more prevalence to dislodgement. You can still use all your ACLS medications and procedures. It's not going to hurt anything. Defibrillation is either anterior, or some protocols like it anterior posterior. You'll just have to refer back to your protocol to see which one they would like. Fluids of choice, of course, the good old normal saline is a fluid of choice, but also lactated ringers is a good volume builder. Depending on their needs, you'll definitely want to avoid anything hyperosmolar or anything that might really spike their osmotic load, since that can throw off the preload even more. And of course, always adjust based on their output and overall hemodynamics. How to treat if in a crisis. So if they're in a crisis, like showing signs of low flow or the perfusion is tanking, first thing is to assess their hemodynamics. Check the LVAD's parameters, um, their blood pressure, perfusion. So you want to troubleshoot the LVAD if possible. There's lights on the LVAD that'll light up. They'll tell you low battery, low flow, um, uh, driveline problems, and it'd be also a digitized message that out to the side that'll tell you what the problem is. So if you can, you can fix that in the field. If not, then you need to be transporting. Then you want to support them whenever, whichever way you can. Fluid resuscitation, maybe some inotropes like dopamine or dobutamine or epi and norepinephrine, if ordered by a physician, while you get them to a higher level of care. Further care will be listed later in this presentation. Patients with LVADs, do they create more right-sided heart problems than normal? Um, LVADs are designed to assist the left side of the heart, but your right side can have some knockoff effects. Since the LVAD boosts the left ventricular ability to pump, it might increase blood return to the right heart. If the right heart is already struggling, it can get overwhelmed. That's why managing right heart function is a big part of LVAD care. So yeah, right-sided heart issues are also known potential complications, so they try to keep things balanced. If I had the choice and I was going in for a ventricular assist device, I believe I would ask them for for both. You know, just to keep that from showing up later. Right-sided failure, your fluid builds up and you need diuretics to get it off, and it also slows that pump down. So your volume uh, will be less and perfusion will be affected. So yeah, it's just a cascade of things that fall behind that. Here's some rhythms LVAD could present with. On the left, you'll see uh, ventricular rhythms with LVAD, and on the right you will see VFib with LVAD in place. Now, when I went to do research on this, um, they were saying even if the heart is in VFib, if the left ventricular assist device is functioning and getting blood past that heart, um, don't defibrillate. But it would be awfully hard for me, um, I guess, as a medic, to think that rhythm is going to sustain life. Uh, that would be one I would want to go to the closest hospital with and get on the phone with medical control and the device coordinator and find out what I needed to do. This is the 12 lead with the implantation. Um, you see the squiggly lines or the artifact. There's going to be artifact in a 12 lead. Now, here's where we get to the protocol. I kind of broke the protocol down so it won't be so hard to figure out because I hate those algorithms where you have to draw a line and go down to AR4 or go to criteria of death, or I like it straightforward, you know. And up at the left side of this algorithm is going to ask you for a sample history. Um, they want to know what kind of medications they're on, the past medical treatments. Have they been to the ERs a lot in the last few months? Um, they're just going to want to know everything they can about that patient. They're going to want to know if it's a bridge transplant or if it's destination. And they're going to want to know an estimated downtime. LVAD, RVAD, BIVAD, TAH is total artificial heart. Check for a DNR, check for a most or living will, and contact with the LVAD coordinator. Can't express that enough. The LVAD coordinator needs to be involved in the beginning and all the way through. Now, here are your signs and symptoms: unconsciousness, pulseless, apnea, poor capillary refill or skin color, altered mental status or decreased mental status, no electrical activity on the ECG, no heart tones on auscultation. Now, this is your differentials, what it could be. See reversible causes below: infection, sepsis, hypovolemia, cardiac arrest, and hemorrhage. Like I say, contact your VAD coordinator as quickly as possible for troubleshooting and treatment advice, but do not delay emergency treatment. Follow patient-specific emergency plan if present. Criteria of death: decomposition, rigor mortis, dependent lividity, blunt force trauma. I always say if you hit something hard enough to knock the life out of you, you're not going to push it back in. Check for injuries compatible with life. Extended downtime with asystole, DNR, and follow the deceased person's policy. Now, you want to do a rapid assessment. You want to check for signs of life, and you assess for adequate perfusion. Criteria for death: no resuscitation, review DNR in most form. Um, a lot of these patients have these forms. Uh, I guess they're getting tired of going through all this medical technology, and it's not helping. So I guess they just want to go be with their family in heaven. No criteria death. Unresponsive but not breathing normally. Assess the LVAD function. Look, listen for alarms. LVAD alarming. If yes, go to page 2. Place a stethoscope over the heart. Humming sound present. If yes, go to page 3. Airway protocol. AR 1, 2, and 3. Respiratory distress protocol. Go to A4. Assume VAD failure. Go to page 8. Go to page 2. No criteria for death. Responsiveness, unresponsive, breathing normally. Airway protocol, secure the airway. Respiratory distress, go to your respiratory distress protocol. Assess the LVAD function and look for alarms. If it's alarming, no, then you contact your medical control. Place a stethoscope over the heart. Humming present. If yes, go to page 3. Assume VAD failure. Um, what you want to do when you're on page 2, attempt to restart the LVAD, expose the VAD control module, expose VAD power source, expose VAD drive line. Drive line, ensure the drive line is connected and firmly in control module. Batteries or main power, ensure all connections are firmly connected to the control module. Battery chargers, check by pressing the charge indicator. Replace batteries if needed. LVAD restarted. Humming sounds over the heart. If yes, go to page 3. If no, continue on this page. Spare control module. Attach the batteries to the spare control module. It may be something wrong with that. Connect to a main power source to the spare control module. Detach the drive line and attach to spare control module. LVAD restart. If yes, go to page 3. If no, continue on this page. Is there humming sounds over the heart? Possible drive line fractures. What you want to do is quickly manipulate the cable trying to restore the brake. If successful, tape the drive line in place. Mechanical circulatory support for LVADs, RVAD, BIVAD, page 3. This slide is for rhythm analysis. If your patient is in VTAC or VFib, an AED or cardiac monitor should be placed on all VAD patients, no matter how minor they may seem. If they've called you for an emergency, your evaluation does not find any obvious signs, always place the patient on a cardiac monitoring and get a 12 lead if possible. Because these patients are going to be sick. They're going to be real sick. So they need your full undivided attention. You're their person as long as you're with them. Now, we're going to reassess the patient for responsiveness. If no, rhythm analysis, VFib, or VTAC, if you have a no, assess circulation, can't refill less than 2 to 3 seconds, end-tidal greater than 20, MAP greater than 50, cardiac arrest protocol if indicated, treat focused CPR, AC311, IV or IO, normal saline bolus 50 milliliters, may repeat times 2, no, times 4. So you have given 2 liters. Once resuscitation and consideration of termination of efforts. Now, this one says VFib or VTAC, do not defibrillate. Assess circulation, cat refill, that is 2 to 3 seconds. End-tidal CO2 greater than 20 milliliters mercury. MAP greater than 50. If no, follow this page. IVIO, normal saline bolus, may repeat the maximum of 2-liter boluses. Contact a VAD coordinator. Transport to a VAD center. Take all spare supplies. That don't matter if you're going for a doctor's office or you're going to an ER visit. Take that bag with you. It has the charger, it has control module, and it has batteries inside. While en route, you want to consider your H's and T's, which is hypovolemia, hypoxia, acidosis, hypothermia, hyperkalemia, tension pneumothorax, cardiac tamponade, toxins, thrombus PE, thrombus MI, and suspect an opioid overdose. And if they've done that, administer Narcan. Mechanical circulation support. Here are some of the pearls. Recommended mental exam, mental status, skin color, cat refill, peripheral blood pressure, assessment of blood flow and perfusion status, optimal BP attained by manual cuff and Doppler. Automated devices are only accurate about 50% of attempts. It is not reliable. And to assess perfusion, mean arterial pressure greater than 60 for most LVADs, skin color, skin temp, and capillary refill. This has been my presentation. These references I've gotten from Facebook. Not Facebook, but Google. There's some YouTube videos in here that are absolutely wonderful. There's the ones that I'm telling you about, the guy who has the implant and he comes off of it. That one is a segmented video. You'll have to keep following what he's doing. But everything else that I've covered is in the references. If you have any questions, you can call me at 910-495-3650, or you can email me at carl.morrison244@gmail.com. I really appreciate you taking your time and listening to me today. Like I said, we don't get these very often, and we only train on it every 2 years and don't spend that much time with it. It's just one of those things we bump over and keep on going. But I was fortunate enough to be given this subject to write a paper on. And once I got to writing the paper, I was dumbfounded at how much I didn't know about it. So, till next time, y'all have a great day. Bye-bye.